A ver, acuérdate que están conectados los de Salamanca. Espera, que vean. Salamanca, ¿nos oís?
Perfectamente.
Vale, vamos a empezar. Va a introducir la sesión el director médico, el doctor Javier Muñoz.
Muy buenos días. Muchas gracias por estar aquí, muchas gracias por estar en Salamanca. Para mí es un placer auténtico presentarles y ofrecerles el conocimiento y el buen hacer de un tan prestigioso cardiólogo como el doctor Bahanian, que también, aparte de eso, es un buen conocedor de nuestro hospital, es ya un colaborador conocido, un colaborador querido por nosotros. Yo creo que todos estos encuentros que periódicamente realiza el servicio de cardiología tienen un enorme valor, un enorme prestigio, bien ganado, y lo hacen, tienen este prestigio precisamente por traer profesionales de este enorme nivel. La sesión de hoy, dirigida al tratamiento intervencionista de la patología de la válvula mitral, espero que sea tan provechosa como parece y como merece el nivel de los participantes en la misma. Muchísimas gracias, profesor. Muchísimas gracias también al doctor Fernández Avilés por traernos colaboradores de este nivel, y muchas gracias a ustedes por estar aquí acompañándonos.
Bueno, buenos días a todos. Gracias a nuestro director médico, el doctor Javier Muñoz. Salamanca, buenos días. Pedro Luis, ¿qué tal? ¿Cómo estáis?
Buenos días, estamos muy bien aquí, deseosos de escuchar la charla.
Muy bien. Good morning, everyone. We will try to continue it in English. Let me introduce again Dr. Bahanian, our friend. As I mentioned yesterday, he is not only one of the best interventional cardiologists in Europe, of course, and in the world, but he's also, as Dr. Muñoz said, a very old friend. He came several times in the past to this hospital. We learned from him a lot of things. I particularly had a great opportunity to learn many things about valvuloplasty and many other interventions. And he is an outstanding cardiologist with many contributions in the field of interventional cardiology, and particularly in the field of valvular heart diseases. In fact, he is for years the coordinator of the European guidelines of valvular heart diseases. So it's my pleasure and my privilege to welcome again Alec to this hospital, which is your house, and also to the other house you have now, is the House of Salamanca. So please, the stage is yours.
Thank you.
So, good morning. It's my real pleasure to be here. Paco told you that we met a long time ago. I think the first time I came was for a life course, and it was 30 years ago. Many of you were not born. 30 years ago, and Paco at that time helped me. But yesterday, I look at Paco working. So the things are changing, you know. No, it was a fantastic memory, and also the hospitality here is great. That's the point. I don't speak only about cooking, but the rest. So the topic which was put to me is a very large one, a very wide one, but it could be of interest, and we'll walk through what we have now to offer to patients with mitral regurgitation in terms of percutaneous approach. First of all, is there any surgeon in the room? No. Okay, good. So now we are free. Huh? Okay, okay. So, of course, I have some conflict, and unfortunately, only in the field of this mitral thing. So you can listen to me, but please don't trust me. So here, just to show that mitral regurgitation is a topic of interest, because there are many patients with mitral regurgitation. And I would like to show you as very preliminary what will be shown by Professor Jung during the Congress in Munich.
It is the latest registry, European Registry on Valvular Heart Disease. I must say that something like 7,500 patients were included, and France and Spain were the first two countries. So thank you for your contribution. What did it show? It shows that mitral regurgitation in green is the number 2. Sorry? No, it won't work. Okay, but I can put my big fingers. But no, but you see what I mean. Huh? Mitral regurgitation is frequent. 31% of the left-sided heart valve disease. So it's quite a frequent disease. It deserves some treatment. And the point is, there is a strong rationale for percutaneous mitral valve intervention. Firstly, you all know, but it's not known by everyone, that having a severe mitral regurg is not good. You're going to die from it, so it's not good to leave patients with severe mitral regurg. Nowadays, patients are often elderly. So what is elderly? Well, Rahim Tullah was one of the most famous cardiologists. He used to say elderly is older than me. You know that? You have to refine your judgments, the young people. Huh? So there are many elderly patients, and elderly means comorbidity. So listen to the heart, look at the valve, but look at the patient. That's something we discussed yesterday several times. Surgery is the gold standard in mitral disease, but might be high risk or contraindicated. Thus, there is a room for something, and even more so, we showed 10 years ago in the other EuroHeart survey that half of the patients with symptoms, severe mitral regurg, were not even discussed with the surgeon, were not even considered for any intervention because the doctors were very, very much afraid of the risk of any intervention. We completely forget that these patients are going to die if we don't do something. So there is a rationale. Now, you know that TAVI works very well. You are aware. So the interventionist, we have a brain, but it's rather small, unfortunately. And we thought that we can jump from the aortic valve with the same recipe, jump on the mitral, and do the same job. Big, big mistake. The aortic valve is not stupid, but it's very simple. You have cusp, a little bit of annulus, and that's it. Here, the mitral valve is a complex. You have the annulus playing with the leaflets, playing with the subvalvular apparatus, playing with the left ventricle, playing with the aorta, etc., etc. If you want to cure a mitral valve disease, you must address all these parameters. And here is a slide from Switzerland. For the aortic, you need a Swiss or even a French knife. But for the mitral, you need a real toolbox or a Swiss knife. So now, which sort of device do we have available, CE mark, in Europe to repair the valves? Well, we have this one, Mitra clip. You know the Mitra clip, which represents 99.999% of the cases performed. We have the young cousin, the Pascal, which looks like it. We have some crazy, stupid things trying to reproduce annuloplasty. We have even more crazy things trying to do indirect annuloplasty. We have a more reasonable, but I'm heavily biased, something trying to reproduce the direct annuloplasty. And we have something trying to reproduce chordal implantation. So we'll walk through these different things. Mitra clip. You perform Mitra clip here, so you know very well the story. Mitra clip, you need a good transeptal. Then you go there. When you're happy, you close it. You evaluate. If you are happy, you release, or and or you put another one. The message from this slide is it's a combo procedure. You need fluoroscopy, but it is mostly echo-driven. What is the consequence? The consequence is you need good echo machine. You have a fantastic machine. You need good echo person. You need, that's for the young ones, you need a good knowledge when you do intervention. You need a good knowledge of the echocardiography, of the anatomy. And the message for the team is you should speak to the others using the same language. Communication is key. That's very important. And with such images, if you have everything on board, it is a very peaceful, a bit lengthy in my opinion, but very peaceful procedure. What is the evidence? I must say that this is from the laboratory, the company. The evidence, it is mostly bombing. Bum, bum, bum. 10,000, 20, 50, 65, maybe 70 today, 1,000 patients. Big numbers, but big numbers do not mean big data. More than 65,000, high success rate. Patients treated are 2/3 secondary MR, 20% degenerative MR, and a new entity came, the mixed MR. Mixed MR. You know, when I was trained in Paris, we had Professor Carpentier saying, well, mitral valve disease, it is a combination. You should be able to identify the lesions, the etiology, and the dysfunction. And he separated grossly the primary, secondary. But due to the reimbursement, the new entity came, the mixed disease. So we'll have to probably fight against it or identify it better. So the mitral clip, I must say, you can learn this technique. And here you see the success rate in terms of reduction of MR in the early randomized trial, in the early days, in 2010, 74% success. And now, in European registries, 95, even 100% in Italy. But we are not Italian, but let's say we ran somewhere around 90, 95. So there is a learning curve, as every technique. But what is the recipe of the learning curve? It is a teamwork. You have to properly select the patient. You have to properly perform the procedure. You need a very good imaging, and you must be very tough when assessing the results. If you do that, you are going to end up with very effective procedure, very high success rate. The mind changes. 5 years ago, 10 years ago, we are very happy to grasp the leaflet. We are good, we are good. Now, you should grasp them well. You should reduce the MR significantly. It's a different story. So, something everybody agrees about, it is a safe procedure. Sentinel is European registry, TVT American registry. Patients are somewhat different, but sound is the same. Low fatality, low tamponade, low stroke, low bleed, etc., etc. It is a safe procedure. We don't need randomized trial to show that. And the most recent data shown from the American registry, you see important reduction, dramatic reduction. Now it is 60% of patients ending up with mitral regurg 0 to 1. Still, something like 35% grade 2 and very few severe MR. So there is a real reduction in MR, and safety is there. Patients are discharged early. That is the big lesson from everyday practice. And now the sort of data we have from mitral clip in secondary MR, there are big data, but poor data. From registry, mixing everything. You have here 1,700 patients with moderate to severe functional MR, not very young, but not very old, very symptomatic, poor LV, and usually receiving good medical treatment. Safety of the procedure is confirmed. Once again, same message, very low risk, that's the message. It is doable, and it is at low risk. Now, what happens to MR? I told you it decreases. Here is a randomized trial, Everest trial, 5-year follow-up. Here is a mitral clip. It goes down, and this slide is coming from the company, you know. So you see this 81% success, but as a doctor, I don't like this 2+. You know, that's remaining 2+ is not perfect. But let's say it decreases, but less than surgery. The good news is it seems that it remains stable over time. So reduction in MR, not complete, but remaining stable. What about the long-term outcome? Here we have only 1 year in this American registry, which shows that patients with primary MR, degenerative MR, will fare quite well, but they are very high risk. So after 1 year, you have 24% of them have some sort of complication, but they are very high risk. But patients with secondary MR, in red, have a worse prognosis because they have underlying ventricular disease. Now, the longest term data we have are from this randomized trial comparing surgery with mitral clip. So there are several ways of reading this slide. The first way is to say, well, in terms of survival and no reoperation, only 74% after 5 years with a mitral clip. It's not good. It's not good. Surgery goes 92%. It's not acceptable in my patient who can be operated. I do agree. It is not acceptable if the patient is a surgical candidate. But on the other hand, if the patient is not a surgical candidate, it's a fantastic opportunity for the patient. The second lesson from this slide is that when you end up after the first month, results remain remarkably stable. So good result at 1 month will remain stable. And the last message is, if we are able to solve, to improve the early failure, we'll go and be parallel to surgery. And this could change the game. And you saw that in this study, it was 77% good result. Now it is 90, even 100. So you see that the future could be good. Now, what about the functional improvement? And clearly everybody agrees and says this therapy gives life to years, even if we don't know if it gives years to life. And patients fare much better after the mitral clip and after 5 years, and it's grossly similar to the result of surgery. So functional improvement is the rule. But there could be some issues, and there could be some readmission after mitral clip, mostly for heart failure, and the predictors of readmission are right ventricular failure, poor RV function, very severe symptoms, and a lot of BNP. So maybe it's not a good therapy if you treat the patient at a very late stage. Does it save life? And the company and many people show this slide saying, yes, patients receiving mitral clip fare better than patients receiving medical therapy. But these slides are very misleading because these are not randomized trials. These are a mix of primary, secondary MR, a mix of patients treated in 2010 and patients treated in 1990. So these results should be taken with a lot of caution. And I think we should try to stay on solid grounds. Have a look at this German study, because in Germany they do many mitral clips, and time to time they can offer us good data. Here you have 1 year follow-up in this big German registry, more than 1,000 patients. It shows that the predictors of poor outcome are very symptomatic patients, patients with very bad ejection fraction, patients with severe tricuspid regurg, and of course those where the procedure failed. So once again, same message, we should not treat the patients too late. So with this data in mind, the US colleague said that in primary MR, this therapy may be considered low level of recommendation in severely symptomatic patients with chronic severe MR who have favorable anatomy and a reasonable life expectancy, but prohibitive risk for surgery. We said exactly the same thing in Europe with a different grading because we did not consider that the Everest study can be used for this purpose. So exactly the same thing, full agreement. But if we move to secondary MR, to heart failure patients with MR, Here, the first guideline released were by the heart failure group, and there are many English-speaking people here, so it was nicely phrased. They said, in patients with heart failure, moderate to severe secondary, who are judged inoperable or high surgical risk, percutaneous mitral intervention may be considered in order to improve symptoms. So, and quality of life, so it's not mortality, it's in order to, although no evidence is available from randomized trial, and we have to do that. So that's a cautious but still a recommendation. In the US, it is not allowed by FDA, and US colleagues said we have to wait for the randomized trial. And in Europe, we went a little bit further, because in Europe there is a very large experience in registries, mostly in Germany, a large experience, and we gave a 2BC recommendation in patients with secondary MR. In those where there is no indication for revascularization, when the surgical risk is not low, this procedure may be considered in patients with secondary MR, ejection fraction over 30%, who remain symptomatic despite optimal medical management. And in the second group, the patient with terrible ventricle, and we had this question from Salamanca, I think it should be discussed by the full heart team with the transplant heart team. And here you have to see if it's worth to give something to the patient before going to transplant or LV assist. But once again, the level of evidence is C, that is to say, well, it was a discussion around the table, we need more data. So that's the clinical indication. The anatomic indication you know very well. Here is the role of the echo. It should be in the middle, especially in primary. You need a good valve opening. You need a defect which is not too large, not too big gap, and not calcified valve. But there are other indications which are proposed as conditionally suitable by the German colleagues who wrote a recommendation: patient with commissural lesions, patient with a little bit of calcium, with a little bit of stenosis, and coaptation depth, which is quite large. And they are definitely the unsuitable, but in very experienced hands, even patients with cleft are addressed, even patients with Barlow are addressed, but no one is willing to go in patient with severe calcification, no one is willing to go in patient with mitral stenosis, and no one is willing to go in patient with rheumatic disease. So that's a proposal for anatomic indication. Now let's move from the big mitral clip to the small stories. This one is coronary sinus annuloplasty, and we cardiologists thought that by going into the coronary sinus, shrinking a little bit, we'll be able to reproduce the surgical annuloplasty. Here is the device in the coronary sinus, very easy to go. Huh? Even myself, I was able to do that. Jugular, you go there, and you enter the coronary sinus, deploy your thing, and then shrink. And there is some decrease in MR. What is the mistake? The mistake is cardiologists spoke with cardiologists, and we did not speak with surgeons. And we totally ignore that the coronary sinus is not at the level of the mitral annulus. It is intraatrial, could be at a distance. Also, the coronary sinus does not cover the whole circumference. We are not doing an annuloplasty, so lack of efficacy should happen. And we may kinch this entity, which is the circumflex artery. So risk and limited benefit. In point of fact, because it's easy to do, because in Germany it is reimbursed, almost 1,000 cases, maybe more now, are done. And it is safe. Of course it is safe. But what are the results in terms of reduction of MR? I'm very concerned by these 40% of patients remaining with severe MR, the rest having moderate MR. Efficacy is not there. And these observations are not randomized. Now, the one personally I do prefer, but I'm biased, I told you, is this one, which was invented by Francesco Maizano, a cardiac surgeon, and other cardiac surgeon. You go around the valve and the annulus, and try to deploy a band. It is exactly what the surgeons do when they do the Cosgrove band, for example. So you go transeptal, you have a little screw here, you screw in the annulus, you are guided by echo, it's relatively easy, and then you deploy a couple of things, 15, 17, well, you should be patient, under echo guidance, and finally you shrink on beating heart. That's the beauty of the thing. You shrink on beating heart, you see the decrease in MR on beating heart. A surgical colleague cannot do that. So what is the status? Probably more than 500 patients treated. It is feasible, good training, but it's feasible. Could take a little bit of time. Safe, yes. It provides a significant reduction in MR, and there is a rationale. With the coronary sinus, you hardly reach 10% reduction in the annulus. Here you reach something like 30%. And after 1 year, reported at PCR after 2 years, you have an improvement in MR, improvement in patient functional status. So there are preliminary arguments in favor of efficacy. What is very interesting is, not like MitraClip, you put a big thing in the middle of the orifice. Here you leave the options open for an additional procedure. Here is the MR, you see the reduction, okay. So now we are also addressing a technique which is similar to the surgical technique. It is to implant cords. You know that cordal implantation is a masterpiece with annuloplasty in the repair of most patients with primary degenerative disease. And here it's grossly the same thing. And usually it's not exactly apical, but it's just below, just here, lateral. And you go and you grasp the leaflet and you obtain a reduction in MR. So you have several devices. This one is a large bore. This one is quite interesting because it's 10 French. So it's quite interesting. There are very sophisticated techniques to do that, but it is doable. What is the status? Many patients treated, mostly in Italy, also in the UK and some in other places. Mostly it's very surprising because it was done by cardiac surgeon, as you can imagine, in low-risk patients. In low-risk patients at this stage of development, it suggests safety, efficacy, but they did target very special group of patients. P2 prolapse, that's very frequent, but minimal or no annular dilatation, which is slightly less frequent in our experience. But if it is done in isolation, you see here a dramatic reduction in MR, despite the fact that they did not add annuloplasty. So it's promising because there is a strong rationale. And here I put a slide with the crazy other devices. I don't want to expand the cerclage, why not? Huh? This one is a big annuloplasty, quite interesting, but very limited experience. This one also very limited experience. This one hopefully will never happen. This one I'm not sure it is in man, and this one is completely crazy. For those who attended PCR London, it didn't work, but okay, it was shown. Huh? So forget it. I think the future is here. The future is here. It is to consider combining treatment. And these slides are from Germany and Switzerland. Combination of coronary sinus, which doesn't work but could help a little bit, and MitraClip. This one is from Switzerland. Real annuloplasty plus MitraClip. That's very interesting, very promising. And in minds where they have everything, good brain, good echo, and everything, they even perform a combo of annuloplasty plus caudal implantation. That's probably almost surgery and using fusion imaging to help. So we can go beyond. You can go beyond. You can do MitraClip and TAVI. You can do MitraClip and appendage occlusion. You can do MitraClip and AFib ablation. Here is a patient probably from Zurich. He has everything. You occlude the appendage, you do MitraClip, you do valve in a valve, and when you go out, you close the septal defect. But okay, I think as doctors, we have to think twice. First of all, we have to think about the strategy. It's good to combine, but how? are we going to combine? Here, always remember, Professor Carpentier, what is the lesion, what is the etiology, what is the dysfunction. So you are going to choose your device according to the patient, but what about the cost? 20 plus 20, 40,000 euro, are you willing to pay that for percutaneous repair? That's a question. Now, let's move briefly to the other aspects, because repair is not doable in everyone, and there are probably 30 companies developing mitral valve replacement. Why is it so? I would say that it's probably a marketing strategy called Me Too. That is to say, you buy a startup, you look at him, oh, he bought, I want to buy, you and you end up by buying everything. So here you see the family. And there are a couple which are emerging, but please, maybe you are at a distance. At first glance, these valves look a little bit big. These valves look a bit sophisticated. A lot of metal, a lot of details could be subject to, problem in the LV, subject of deterioration, subject to thrombosis, subject to dysfunction. So it's not an easy game. And another approach, and I think it's probably the most interesting one, is to install a docking device. And in the docking device, you put the Volkswagen. You put, let's say, something like the Edwards valve we put yesterday. That's very simple, but unfortunately, there are few patients treated, maybe 10, 5, and 10. So very few patients treated, but it's promising because it will be more versatile, and the profile of the device will be lower. Today, we are playing with device 30 French, 35 French, and here we may hope dealing with 15 French. So what is the huge experience today, reported by my friend, Professor Badia, a few weeks ago at PCR? It's less than 300, less than 400. It was a symposium run by Abbott, so the Abbott product was first, but okay, it's not a lot, 140, 80 with the Medtronic, 50, 24, 12, and 12. Low number, preliminary experience. So what are the results? When we saw the result first time at PCR, it was with this thing, 13 patients, all extremely symptomatic, well, not so bad. Technical success, all are transapical. Technical success. The good news is 0 residual MR. You replace the valve, 0 MR. Almost 40% 30-day mortality. It was a catastrophe. And the most recent publication, now they are published, most recent publication, slightly higher number of patients, less sick patients, higher success rate, no MR, almost no MR, and fatality dramatically decreased. Dramatically decreased. Why is it so? The device could be better, but the big change is that only 30 to 40% of the patients presented for inclusion in this trial were rejected. That is to say, the difference between the first one and this one is drastic patient selection according to clinical presentation. They were not almost dead with a 10% ejection fraction, and also selection according to anatomy. So that's the recipe. We discussed that yesterday. Now, which sort of long-term results do we have with transcatheter mitral valve replacement? The largest series I was able to show is a huge series of 5 patients with a very long follow-up of 6 months, 2 years. Patients fare better. There were no major dysfunction on echo, but we recognize a problem, LVOT obstruction, a little bit of PVL, and obstructive thrombosis. We recognize a problem we may have with the bioprosthesis. So we don't have real follow-up. And there are plenty of challenges. I told you these are big device, 30 French plus. Most of the cases are done transapical. That's a problem. Aligning the prosthesis is not easy. Sealing is not easy. LVOT obstruction, etc. what is the effect of a transapical introduction of a 35 French device in the apex with poor ejection fraction. Risk of thrombosis, it does exist, and durability, we don't know. So here is you can see a summary of how to fix this valve, tethering, barbs, paddles, tabs, etc. And here is the most important thing. To predict the thing, you have to do some sort of simulation using sophisticated imaging in order to avoid the risk of LVOT obstruction. That's very, very important. So is it possible, it's very popular to do this comparison between transcatheter mitral valve repair and replacement. Is it fair? No, it is not fair. You compare a very young technique replacement to a slightly older technique. Replacement definitely is easier. It's a technique, transapical, it takes 30 minutes. Now with a prototype transeptal, it takes grossly the same time, but it's simpler. You can put a valve, whatever the etiology is, more reproducible, and you won't have any MR to finish. But they are huge devices. Durability, we don't know. If there is a leak, it's not good. Hemodynamics is not perfect. Repair is more natural. Throughout all the techniques, we can see, yes, it is safe, but it's more complex, but there are selected indications. There is a longer learning curve. MR reduction is there, but it's not total. And durability, we don't know a lot. So, and now why not going and doing some percutaneous or at least minimally invasive things to play also on the ventricle? This is being revisited now. So we cannot make a talk on mitral valve repair without addressing tricuspid, because tricuspid should be tackled if it is severe in many circumstances. And now there are cases reported of combo approach with the mitral clip here, mitral and tricuspid. You go, you deliver the, you take it off, you pull, and then you redo the same thing on the tricuspid. Or here you have a mitral clip here and quite a sophisticated tricuspid thing in order to bicuspidalize. But it has been done. What is the total experience of combo? It is very limited. 22 patients, 12 patients, in very super expert hands. Super expert hands. Success rate is very high. Duration of procedure only 2 hours, which is nothing for this procedure. No risk, no fatality, but the weakest part of the combo is a tricuspid, and there is incomplete reduction of tricuspid, and there is a moderate improvement in functional conditions. So let's say, very first step, but should be considered in the future. So final comments. The first comment I'd like to share with you when discussing the percutaneous intervention on the mitral valve is a pathophysiological question. Is secondary MR only a variable associated with adverse outcome, or is it a real risk factor? So is it the chicken, or is it the egg in patients with poor LV function? Well, we do not really know. The data we have come from a relatively small series. Here is a series in Germany showing in 250 patients, mostly with functional MR, but not all of them. And they look at what happened in terms of symptoms in patients with very low ejection fraction, moderately low ejection fraction, and somewhat acceptable ejection fraction. And you can see that there is a dramatic improvement in symptoms, even in patients with very low ejection fraction. So putting a clip throughout the registries in patients with very low ejection fraction seems to improve the symptoms. Of course, it is only observation, small number, and not randomized. But there is something which is concerning in this study, which is not a very good study. It's mostly echo study, but suggesting that in patients with somewhat, not catastrophic ejection fraction, you may improve the pressure volume curves, which is not the case in patients with very low ejection fraction. The methodology was not perfect, but here the message is quite clear. There might be no effect on the ventricle. So it means there might be no real lasting improvement in this patient. So we really don't know. And the way to move forward is to phenotype this patient. And one first step in phenotyping is this very interesting article published in European Heart Journal. They took a group of patients with chronic heart failure, secondary MR, and they look at the patient where secondary MR plays an independent predictive role. So what could be the target, the patient to treat on the MR if we want to improve their outcomes? And they very interestingly showed that if you treat the patient who are not very, very sick, you may do something. If you treat the patient with only, let's say, not catastrophic left ventricle, you may do something. If you treat the patient who do not have a very high BNP, you may do something. So here the same message is coming again. You may do something when treating the MR in this patient if you treat them quite early. But here you have a problem, a paradox. You should give a medical therapy, optimal medical therapy, give it, but look at the patient. Don't accept, well, I give you a medical therapy, come back next year. No. You should look at the efficacy after a few weeks, a few months. If it's not effective, consider something else. So the message is phenotyping the patient with functional MR is probably the way to go. Now, another thing is this procedure should not be done in every single small center. You need to have real heart valve centers with multidisciplinary heart team, with a good knowledge of imaging and good collaboration between everyone. And the heart team in these mitral things, and also tricuspid, of course, you need cardiologists, but you need to include the heart failure people, if you have this sort of people, EP interventionist, good anesthesiologist, good surgeon, and essential, crucial, imaging specialist, not only echo, but also CT. For the young people, if you want to learn this technique, if you want to have the full spectrum, you should gain knowledge in CT. So, what are the steps? When you see a patient referred to you for eventually treatment of a severe MR or severe TR, the first question should be, is the regurgitation severe? That is the role of stethoscope, of course, but also a little bit of echo. Second question, what is the mechanism of MR? It was not done in Everest. It was a mix of everything. Is it primary? Is it secondary? Or TR is the same. Is the patient symptomatic? Are there contraindications to any intervention? The patient has a cancer with metastasis, the patient has no lung, the patient, etc., etc., etc. That is very important. This patient, it is futile to envisage any intervention. Now, you should discuss with the heart team, anesthesiologist, cardiac surgeon, is surgery contraindicated or high risk? And here, it's not the scores only, it is the assessment of many parameters. And then you should see, is transcatheter valve intervention feasible? Yesterday we discussed the calcium, we discussed the annulus, etc. This sort of discussion should be done. And finally, what is the decision of the heart team, transcatheter or medical therapy, if surgery is contraindicated? And you should follow these steps. If you jump over one step, you are going to make a mistake. Follow these steps. And try to avoid this. Of course, treating this very nice lady is useless. But is it wise to do what was done and to do what is done? That is to say, to evaluate chordal implantation in patients with a risk score below 1% for surgery. Well, in a randomized trial, I think it could be done, but we have to question, and I'm a bit shocked ethically by what was done in hundreds of patients out of any randomized trial. That's a very important point, but in point of fact here, it was in the very early days of percutaneous mitral intervention, we thought that this technique could be done first and delay the timing for surgery. But now we know that it's a different story. So imaging is key, but it's not a simple echo. it's multimodality imaging. Yesterday you saw that. And also, we should be ready to face an expanding role of simulation. I think echo will remain the cornerstone. Will remain the cornerstone. You, young people, have to learn echocardiography. And I think if you want to become a structural interventionist, valvular interventionist, you should spend at least 6 months, 1 year in an echo lab to learn echo. Then you have to learn CT. Here is a sort of CT reconstruction which is done before a cardioband. We know exactly where we have to puncture. We know exactly where we have to put the screws and how many screws, etc., etc. Also the relationship with the circumflex artery. Reconstruction here is something we are working on with the Cheops company to see where the valve can be, where the valve should be. And during the procedure, if you are rich enough, you may have this combo visualization with TEE and also echo and imaging, guiding your transeptal puncture. I think it's useless in many cases, could be helpful in very sophisticated case, for example, paravalvular leak closure. So, revolution in imaging, but please, for the younger one, you should invade the CT labs. You should not let the radiologist do this job. It is too important because we are taking care of the patient, and you should learn how to interpret CT just as you do for TAVI. That's a very important message. Now, where will be imaging in 2025 in this field? That's a statement by Patrick Sterois, published late last year. Improve and more widely co-registration in the CAS lab, advanced imaging for case preparation, 3D printing, yesterday there was a question, for complex cases, had not been proven, but very good. And the big problem, the mitral is a problem, tricuspid is a huge issue. Now we need evidence. And here is the field of TAVI. You see the randomized trial in the field of TAVI. In the field of mitral, I should say there is a gap. There is a gap. Fortunately, if you come to Munich, you are going to see the first randomized trial in secondary MR. After a few weeks, you see the second. After a few weeks, you'll see the third. So there was a lack of evidence. What are the trials on MitraClip in functional MR? You have the American one, the COAPT, a pan-European one, the Reshape, the French one, MitraFR, a German one, Matterhorn. They are going to compare the optimal medical treatment with MitraClip. The severity of MR is slightly different across the study. Patients are extremely symptomatic. Endpoint is either hospitalization either hospitalization for heart failure or death and hospitalization, slightly different. And the ejection fraction are catastrophic and bad. So the results will be of great interest. Now there are trials, randomized trials, on their way with annuloplasty device. Unfortunately, they are mostly on their way in the US, because now everything happens in the US, and we Europeans are a bit lacking behind, but this one is with the good annuloplasty, this one is with the so-called indirect annuloplasty, but we'll get the result probably within 1 or 2 years. Now, in France, we are just starting a trial in MitraClip in primary MR in patients slightly at lower risk, and I think that this one is very important because it's a potentially very important indication of the MitraClip. And now there is the last trial I want to mention is this trial on transcatheter mitral valve replacement, which is going to be compared in a randomized way with the traditional mitral valve surgery. So there are plenty of trials coming. Now, I told you as regards the treatment, that is what surgeons are doing to repair a mitral valve. A fantastic menu à la carte according to lesion etiology. That is the surgical thing. We should think combining. In the middle today is a leaflet repair. We have annuloplasty. We have chordal replacement. If we cannot do that, consider valve replacement. It's not a competition, should be an addition, and that's very important. What we need to do, what we need to be able to do, is to do a comparison of combination of percutaneous technique versus surgery. I don't know if it will be possible. Now, what will be the future of mitral valve intervention for the group in neurointervention? They clearly claim that percutaneous leaflet repair will be the preferred option, sometimes combined with annuloplasty. I slightly disagree. I would say that repair will be preferred over replacement, but I do think that annuloplasty will have a key role as it has in surgery. Replacement will be indicated for selected patients, so second row, and transeptal approach will be most preferred against transapical, and what we need is a toolbox to perform this repair, and that's very important. Now, a point is good to do trials, but it's very important to look at the practice. And with my colleague Bernard Jung and other friends, we run at ESC this study, which was only by interview. We interviewed during some time people in 7 countries. We interviewed GPs, interviewed general cardiologists, and specialty cardiologists, and they were shown 3 case scenarios. One of them was a secondary MR, patient, 50 years, symptomatic, CVMR, not treated medically really. And the bad news is, even if the guidelines claim that you should start with medical therapy in these patients, only 33% of the cardiologists do that, start by improving the medical treatment. On the other hand, in the rest of the story, we told them the patient did not improve after optimization of medical therapy, and not all of them, by far, considered any intervention. So it shows, it was done this year, shows that education is not properly done, especially among GPs who perform auscultation only in half of the patients they see. And now we'll see the practice in Munich with the Eurard survey. I already said that. Now the last part of the improvement will come from the new devices. Here is a small listing of the new devices available this year. The devices which have CE mark, etc., this one. The other one are on their way, but please look at the mitral valve replacement. It's 30 new ideas, even if it's probably coming after mitral valve repair in the future. So it's very, very interesting to see what is in the pipeline. But it's very good to have a fantastic menu à la carte. If you don't have money in your pocket, you won't eat the meal. And here is the illustration from EAPCI in Europe. Sonia did a survey. She looked at TAVI centers, 300, and 30% claim that they do not perform mitral treatment because of economic reason in over two-thirds of them. So economic issues should be considered. And here is a slide from the Atlas. It's not published. It was shown during PCR, showing the use of transcatheter mitral valve repair, mostly MitraClip, of course, per million inhabitants in 2016. And you see that there is somewhat of a difference between Germany, 64, Switzerland, 44, Italy in certain regions, 16, and then here you are, 5, congratulations. Here we are, 3, and UK is 2 point something, Romania, 0. So let's say there is clearly a big gap between different countries according to the GDP, according to the system, etc. So, dear friends, dear colleagues, to conclude this too long talk, we have plenty of things, but we are facing even more challenges. The challenges to me are, first of all, is it useful to do any intervention on the mitral valve in patients with secondary MR? We don't know. We'll have some sort of answer in the coming months. We'll have to evaluate this MitraClip in patients with primary MR, so-called intermediate risk, not the terrible one, not the wealthy one, but the one in the middle. And we have to evaluate all the other techniques. First of all, I will put annuloplasty, the real one, chordal replacement, yes, because this one reproduces surgery, combo, and mitral valve replacement. Then we'll be able to know who is repair, who is replacement, and we'll have to work in parallel to the tricuspid solution. So you asked me to answer this question. I think we are at the end of the beginning. But I have a very good news for you coming from Germany. And here is a slide from my friend von Bardeleven showing what happened between 1995 and 2017. The first lesson is the mitral clip, the transcatheter mitral valve repair, is going up. Last year they performed, it's something like 6,000 patients treated in Germany using this technique, a steep increase. That's good news for mitral clip user, for the company, etc. But the other news, which is even better to me, is that the patients are coming more and more. And the number of patients receiving surgical mitral valve repair is also increasing, and the number of patients receiving mitral valve replacement is slightly increasing. But the final result is that more and more patients with MR are treated. Remember, 10 years ago, 50% of patients with severe symptoms, CVMR, were not treated. Now, thanks to the attractiveness of the percutaneous approach, more and more patients are treated by less and less invasive surgery or interventional cardiology. So that is the optimistic view. Thank you.
Many thanks, Alec, for this terrific keynote lecture. Many thanks. The lecture is open for discussion. Maybe we can start with Salamanca. Pedro, are you ready for the discussion?
Yes, we are ready. First of all, thank you so much, Paco, again, for giving us the opportunity to be part of these meetings. And thank you, Alex, for your wonderful presentation. It was a wonderful talk. We have some questions, Alec. Maybe we can start from Salamanca. I have some questions for the interventional cardiologist. So I will let Ignacio ask you a couple of questions, and later on I can go with some other questions. Ignacio, do you want to start?
Again, repeat our congratulations for a fantastic presentation. And our first question is regarding what do you think of, you have talked a lot about the future of this. Do you think there's still any place for transapical approach, or is going to be everything transeptal in the near future? I'm talking about repair and also valve implantation.
Okay, well, thank you for the question. I think now the way is open for transeptal. More and more people are embarking. Okay, for mitral clips there is no discussion. For annuloplasties there is no discussion. For chordal implantation, I think it will remain for many years done transapically. And for valve replacement, it will remain done transapically for many devices, not for all. And I cannot elaborate, but I can tell you that there are at least 3 devices which are implanted successfully transeptally, and this will be done because we are very concerned by the interatrial septal defect, which is at the end not a problem, very much concerned by the alignment, which is also perfectly doable. So I think in the future there is a very strong trend toward transeptal. I don't know how long it will take, but it will be probably the vast majority of cases done. I'm sorry, what was the second question?
No, that was the question, because the question was related to who is going to do this type of intervention. Well, interventional cardiologists, cardiac surgeons, okay, both together, or what we are going to do?
No, I agree with you. Well, you know the answer in the bottom of my heart. But let's say in France, for example, the one who is going to present the mitral affair is a cardiac surgeon. I think we shouldn't be inclusive. If in a group the cardiac surgeons are really willing to do it, I think you should have an agreement in the group and do it. My perspective is that interventional cardiologists will do in collaboration with cardiac surgeon for patient selection, and if they are interested, we'll do the job. But for example, for chordal, implantation. I think it's very special, very specific, needs a very good knowledge of the surgical technique, and I would consider that surgeon will remain the key players here. But, you know, the distinction between cardiac surgeon and interventionists in the field of valvular disease could be a little bit old-fashioned. I think there could be initiative, there will be initiative between ESCTS and ESC to propose in the future a sort of common trunk, and then people acquire the same knowledge and will become either cardiologist, interventional cardiologist, or surgeon. So in the future it may change this way, but let's say majority will be done by interventionists.
Okay, thank you.
There are two clinical questions in the audience, Alex, that I would like to know your experience and your approach, and also the approach of Gregorio Marañón. The first one is regarding mitra clip. We have a lot of cases, and the number of cases are increasing, of patients with very low ejection fraction that we present here in the clinical round for mitral clip implantation. And you have shown to us that the result of these patients with very low ejection fraction are not that good. So my question for you and also for Gregorio Marañón is whether you have a cutoff point to decide to go ahead or not. We know for the trials that 25% could be our cut-off point, but I would like to know your experience. Thank you.
Well,
and also Gregorio Marañón.
Yeah, okay, thank you for the question. It's a very difficult question. I think for the time being, the answer is very easy. In France, we cannot do patients with secondary MR. We are not reimbursed, we are not allowed to do that, so the answer is very simple. I think, well, there are indirect experience, there are registries, there are observational studies suggesting that it improves the symptoms, but we don't have a controlled medical treatment. No real efficacy shown in terms of survival. So if you want to play on the symptoms, there are arguments pleading in favor of improvement of symptoms, but we do not have a randomized trial. So really I can only repeat what I said. Let's wait for ESC, for TCT, and probably by the end of the year we are going to have better evidence to support a decision. I'm not sure we'll have a clear answer, but we'll have better evidence. For the time being, without this evidence, I think it's really a matter of discussion, local discussion with your heart team. If the patient is not too advanced, if the heart team, surgeon and cardiologists do agree to go for mitra clip, go to mitra clip. But if the patient is planned to have potential transplant within 2 or 3 months, I think it's useless to go for mitra clip. So that's the only thing I can say today.
Any comments from Paco or Gregorio Marañón regarding their approach?
Hello, Pedro.
Okay, I have another...
Pedro,
Wait. Jaime is talking.
We have the same problem that you, that we have performed several cases like you are talking about, and the problem is we have several patients that going well with the mitral clip, but there are some patients that don't going well. And we don't know exactly why that difference. And we don't have any cutoff now, but we look at several things. First of all, ejection fraction, of course, right ventricular function, BNP levels, because if the levels are very high, it's not a good thing for the future, and pulmonary hypertension. With this and probably tricuspid regurgitation. No?
Yeah, I think
but there are no clear cutoff. No? It's everything combined with the clinical situation and the characteristics of the patient. But we don't have an answer now for that.
I do agree. If you look at the TRAMI, the German registry, I think it's a very important trial. Up to now, it's probably the best data we have, showing exactly what you said. Because
but I agree with you.
We were fooled by the initial presentation by Olaf Franzen showing that, well, you put the mitra clip and now they jump. No, it's impossible. It's impossible. We know they don't jump. Sometimes they may lie down. In point of
There is also a clinical question from here, Salamanca, is we have a lot of patients that are good candidates for TAVR. They are very elderly. They don't want to go to surgery. And we find that the mitral valve has calcification and has severe mitral regurgitation. And we don't know what to do, whether to go ahead with the TAVR, whether to stop. And I would like to know your currently approach and the future approach of these patients, because I have understood that some of them could have technical issues and difficulties implanting two percutaneous valves. So I have understood that implanting a percutaneous mitral valve combined with aortic valve could be, we could have difficulties with the left ventricular outflow. So I would like to know your current approach and the future of these patients.
Okay, thank you.
And also Gregorio Marañón would appreciate their opinion.
Yeah, okay, thank you. Here again, I would encourage you to come to Munich because I'm going to give a talk on this topic. No, I think we have nothing. We have no data, no real data, and a series of patients having a combo treatment, mostly come from Germany, are published in very, very second-rank journal, or they are multicentric study adding one patient plus one patient, so we cannot draw real conclusion. A recipe is to follow what we wrote in the guideline for surgery. If your patient has caudal rupture plus severe aortic stenosis, if you tackle only aortic stenosis, you're not going to help him significantly. On the other end of the spectrum, if he has severe aortic stenosis, LV dysfunction, and secondary MR, moderate to severe, whatever you want, it's a completely different story. In the second patient, I go for TAVI and observe what happens. And there are a couple of things, mostly coming from Bern. It's quite an interesting study showing that MR is really a significant predictor and won't disappear in patients with primary MR, in patients undergoing TAVI, but secondary MR is not a strong predictor. So that's a very simple recipe I can propose. According to the type, try to tackle the primary and leave alone the secondary. If the patient doesn't fare well, if the MR is still important, you can come back with the mitral clip. In the patient with severe caudal rupture, if you can do the procedure in two times, I think it's better, you can try to address the caudal rupture and the degenerative MR using a mitral clip afterward. That's my proposal.
Pedro, here in the Marañón, we fully agree with Alec Bahanian, and we'd like to ask the audience here in the room for questions or comments.
Yeah. I agree with Alec, but the problem is that in these very old patients, sometimes you have a mixed mechanism. You have secondary and also a primary problem with calcium, as you said, and sometimes it's very difficult to know exactly if this mitral rotation is going to improve after TAVI. Yeah. And it depends each patient. You have to discuss with the team and take a decision.
But you agree there is no rush. Huh? You do the TAVI and you see. Yeah. But if you have a clear caudal rupture, I think you won't solve the problem. You won't. It happens. It's quite rare. I must say it's quite rare.
Well, questions and comments from the audience here. Lilian?
Thank you very much for your review and sharing your point. I have 3 questions. So first you told that, but they will be fast. Okay, first, obviously you told that surgical risk should be evaluated to decide what we have to do with the patient. But I think yesterday's study was published in JACC on the degenerative prosthetic MVR and transcatheter valve-in-valve in patients with significantly high surgical risk had exactly the same results after 1 month and 1 year compared with reduced surgery. So what do you think about the future in this particular...
Okay. We can stop here. Yesterday I was here, so I didn't read JACC, but you mean in patients with high risk?
Yeah, in patients with...
Redo.
redo surgery compared with transcatheter?
Yeah, but I would say I would like to read the paper. But once again, it's always a discussion within the heart team. But at least in our hospital, surgeons are very happy to see us doing the procedure percutaneously in redo patients, especially if they had multiple operations, especially if they have bypass, etc. So that's a matter of discussion. If everything is positive for transcatheter, and if the surgical risk is prohibitive or very high, I think you should go for transcatheter. If you are in between, it's a matter of discussion, individual discussion, and I do not think that there is a single answer. It depends on the patient. Yesterday, I think it was a very nice example. We went through the steps. We went through the steps, and here surgeons are very important players. You discuss with them, etc., and you end up with a strategy. I want to read this paper. In point of fact, I did not see it, but you have to be very cautious. Registries are helpful, but once again, registries, you put very diverse experience, you put very diverse mind in the heart team, and I would pay more attention to the single center, or at least a limited number of centers with large experience and same approach. We have to be very cautious, because the redo is not a redo everywhere.
Mm-hmm. Okay, and I will just go to my last question, because the second is not so. So you were the chairman of several guidelines.
Only two.
Okay.
The third, I was a soldier. Yeah.
Okay, so, and that means that you believe in the guidelines, and
yes.
me too, and there is a lot of evidence that following the guidelines improve the prognosis of the patients. For me, it's a little bit of concern, because I think we still have a room for improvement in the guidelines implementation, and the new concept of precision medicine is introducing in all this. So I'm a little bit concerned about the message which will this precision medicine introduce in following guidelines, or we have to follow that precision medicine. How do you fit the field of precision medicine in valvular disease or interventional cardiology? What do you think about that?
That's a very good question, but very, very difficult question. I'm a believer in the guidelines if you do not work with a black and white attitude. Yesterday, for example, we saw patients who are clearly out of the guidelines. So you have to treat your individual patient. Guideline help you, but guideline doesn't make the whole thing. That's what we tried to do, for example, with TIVAR. We get rid of the scores. We said the message is, please look at the so-called intermediate lower risk patient as a team. Here are the parameters you should check. And then you make your judgment on this parameter, which have been shown to be predictor. That's it. I think it's far less arbitrary than saying if the STS is between 4 and 8, you do that. If the STS is over 8, you do that. Because it has been nicely shown that among patients so-called low risk, when they are discussed, there is a nice paper by Serois in the European Heart Journal. Among the low risk for TAVI patients, half of them are considered as contraindication by the heart team for reasons, radiation, etc. So individualized medicine is very good. Take the guideline into consideration, but you won't find everything in the guidelines. That is life. You have to read them and then make your own judgment. People don't like that. People want to see, you open the app, you click, you see, you should go for surgery. You should go for TAVI. No, it's not that easy in life. You have to individualize. I think the discussion yesterday was very, very interesting. And what is the message from the guideline? I think it's 1, 2, 3, 4, look at the patient, etc. Follow this. Here are the parameters you should check, and then discuss as a heart team. I think it's the future. And then when you define a strategy, what is very important is to evaluate it. You said following the guideline improve the outcomes. We have to show that. And in the EOR survey, that will be the principle of the ESC registries, which will be performed 2 years after the guideline with a focus on the level 1 recommendation. And we'll see if they are well followed and if implementing them brings a better survival, better quality of life to our patients. That's the only answer I can give you today.
Javier.
Regarding this issue of trying to get a little bit more individualized, what do you think is the role of looking at the ventricle with a little bit more detail, more than EF and volumes? All this new MRI-based techniques of scarring, diffuse fibrosis, maps. Do you think eventually for the patient selection for secondary MR, do you ever consider this issue where it's only based on standard EF and volumes and so on?
Well, I must say that in our place, MRI is in the radiologist's hand. We have a difficult access. I know that in the UK they don't use MitraClip, but they do MRI to every single patient because it's very highly reimbursed. So I would say we need more data. I think we start seeing some data from the UK on the prognosis value of the MRI indices for MR, but we have very limited data. But I do agree with you, when you are hesitating, it's good to add on other techniques, but you can, echo, for example, ERO, ejection fraction, etc., they are based on prognosis more than on the real value in terms of assessing the contractility. So what we want is to improve the patient. That at the end, so that's why indices who show a predictive value for prognosis are the most important. But once again, when you are facing a difficult situation, you may add the technique in order to make your point. I think today we need more data on the prognosis value of MRI in MR. Also in AS, most of the studies on fibrosis were done in symptomatic patients. We should not extrapolate and think you should operate asymptomatic AS on the level of fibrosis, because you are taking information from one group of patients, applying to the other group of patients. So I think a lot of work is in front of us.
Alan.
Hi, thank you for your presentation. In our little experience of MitraClip implantation, I have one question for you. That's specifically is your opinion about this kind of patients. In two patients, specifically with functional MR, one of that two patients was with a familiar idiopathic, familiar dilated cardiomyopathy, and the other one was an idiopathic dilated cardiomyopathy. But these two patients, the evolution was very bad because, for example, for the familiar component one, the decision was probably take like a palliative manner to waiting for an advanced heart failure treatment. But I don't know, what is your opinion in this kind of patients? Do you think it's have any role or not in this specific group of patients?
We are not there yet. The data I showed you, for example, the Everest, it was a mix of primary, secondary. When you see in the registry, you hardly see a differentiation between ischemic and non-ischemic etiology. There are some sort of post hoc analysis of registries. Nobody enter into the very specific subgroup you are discussing here. So I have no precise answer. We had the same situation, and we had the same poor prognosis. I think it's a matter of discussion, once again, with the heart team. And you have heart failure specialists, people who know the outcome of this patient. You have the surgeons. Are the surgeons really willing to do transplant quite early on, etc.? It should be a matter of discussion, but you have no data on which you can base your judgment. Today we have a sort of big basket with pears, apples, etc. To me, the solution for the future is to try to phenotype the patient. Let's start modest, primary versus secondary. Then within secondary, you should separate the ischemic with localized scar, severe MR, and not that bad global left ventricle, from the excessively dilated cardiomyopathy. You have also to look, and we have to work on the patient where annular dilatation is a key player, and the ejection fraction is not always that bad. So we have plenty of phenotype, and we have to, if we consider that we have to continue with secondary MR, we have to phenotype the patient. We are at the very early things, and we cannot extrapolate, but the only solution is to bring the people together and try to balance for best the risk-benefit. But we had one patient like that, And yesterday we discussed that. He crashed in the cath lab. We closed the mitral clip, and we had to put an ECMO, and then he ended up transplant. It was immediate, a few seconds, even if we opened the mitral clip, of course. So it's a very, I don't like this subgroup, but it's, you know, 2 cases, nothing.
Okay, we have to close the session. Salamanca, many thanks for the connection and many thanks for the participation of all of you. And also many thanks to all the audience here. And of course, thanks again, Alec, for your visit, your fantastic visit. Thank you very much.
Thanks for the hospitality. Thank you. Thank you.